Good afternoon, everybody. Welcome again to the series webinar on UHC for reforms with a specific focus on health financing. With us today is the team behind arranging the webinar. We're heavily supported by Georgina Bonnet from WHO and Dr. Valeria Makori, the current acting head in health financing, the Ministry of Health. With us also is Nelson from KNH to support us. So without further ado, last week we had sessions from remarks from WHO, from Ministry of Health represented by Dr. Kiptui, from Dr. Wangia, who gave us a brief overview of UHC reforms. We also had Dr. Tracy from SHA with Hazel, the directors from SHA. So we noticed we had a lot of questions. We could not address all of them considering the time. So today's episode is purely focused on the questions that were asked on that platform. We're still monitoring, so you can still use the Q&A box to ask the questions. But without further ado, we will give a brief session. Today, the moderator is presenting. And basically, we have these three contents that are lined up. The main focus of today's discussion is the access to presentations and materials. Two, summary of the UHC reforms, which Dr. Valeria will give us an overview. And three, we'll go through the questions and answers that were done last week. In terms of access, the recording of this session will be uploaded on the KNH UHC platform, KNH Research platform on YouTube. There's a link. In terms of presentation, we will be putting it on the chat box on the webinar on live. That way you can actually download the PDF for those people who are able to do it. For other frequently asked questions, we will direct you to go to the SHA webpage. Then this one, Dr. Valeria, I hope you'll be able to, I hope you can hear me. Dr. Valeria?
Are you able to hear me?
Yes, with echoes, but yes.
Okay.
So the doctor, the floor is yours.
Take you through summary of what we discussed last Thursday on matters UHC. And this is just to remind us that UHC has been a journey, and really that land on the way. A fourth attempt at government. It's not easy. It's like we have to think.
Sorry, Dr. Valeria, I don't know, I'm unable to hear you very well. I'm not sure if I'm the only one. Nelson, kindly confirm.
We seem to have lost her, but I can see her trying to get back online.
Okay. Valeria, are you with us? While we're waiting for Dr. Valeria to discuss, just as a summary, we all know that Kenya has been on the journey for UHC reforms for a long time. And the specific health financing model that has been used has been different over time. And we're actually using evidence-based methodologies, of course, with new entrants. Previously, we had an input-based financing model. Social health insurance is more of a output-based way of financing. So it's really hybrid, and we're hoping at the end of this session, we can be able to aggregate all this information to understand how the Ministry of Health is approaching it, how also WHO is guiding, and how the thinking process behind these reforms have been constituted. It's a commitment from all health sectors and government. It's also progressive, and you have to start somewhere. And it's not like we're starting today. We've been starting this for a very long period of time. And Valeria, if you can join in any minute. I'm holding for.
Okay, yes, I'm back. I hope I'm audible.
Yes.
Oh, great. Yes, and I think I left it at the point where, of course, the first objective is access to quality health services relative to need. And also that with this aspiration that we leave no one behind, then the plan is to cover the whole population. And of course, key to that, what are the safety nets we have put in place to safeguard households from catastrophic health expenditure, and therefore the matter of financial protection. And I think that is where the call is, can we prepare fast instead of waiting until our health is not good to seek that care? So with that, of course, we are guided. Our policy or our approach is anchored under the UHC policy, and of course, the Kenya Health Financing Strategy. And I know for all who have been in the health sector space, developing the strategy took over 20 years for it to come to life. And so with that, all this is aligning to the UHC reforms. And of course, with the government of the day, a couple of UHC reforms. And key to that is, how do we raise revenues? So do we do a mandatory approach, or do we let it be voluntary, noting that the health insurance uptake still remains at 26%? Of course, the issue of reducing donor reliance. And of course, as you all know, right now it has hit us hard with the new administration, let me say the Trump administration. And yes, as part of the government plan, really is, how do we reprioritize and reorganize the health system? And I know we discussed the issues of the human resource for health. There are a couple of action plans that were put against that. The community health promoters, we had, how do you get additional staff? All that had been spelled out in the manifesto aligning to the UHC reform. We know the issue of the health products technologies, the issue around local manufacturing, how do we manage prices? How do we leverage on bulk procurement? All that as part of the action plan. Of course, leveraging on the health information system. I know we're all aware of the digitization agenda that is ongoing. The other aspect, of course, in terms of reorganizing the system, the service delivery. Of course, now the approach is primary healthcare approach, and of course, with a gatekeeping mechanism in place. And lastly, of course, which is what brought us here today, is the health financing. How does health financing look for us as Kenya? And of course, we take note that the health expenditure, as per the National Health Accounts, reports it at 550 billion. And we know that there are various players in that. Of course, the sources, we can say the government contribution stands at about 52%. The partners substantially reduced over the years at 19%. Of course, key to that, what we need to really work on is the households, especially through the out-of-pocket expenditures, stands at 24%. And we have also the corporations of the private sector also being part of this space at about 6%. So with all this, the landscape looking, then how do we want to deploy our UHC? And of course, as informed in our last discussion, of course, health financing has three main functions, of which one is resource mobilization. And who is responsible and what does resource mobilization look like? Of course, we have to mobilize who collects, how do we allocate, how do we distribute, especially in an equitable manner. And all this goes back to, of course, approaches the government has deployed over the year, like having one entity collect the resources in government institutions through e-citizen. Of course, leveraging on digitization agenda. We also take note, the government plan it's a zero budget. So we have to work on efficiency. How do we reduce the technical efficiencies, the delays in disbursement, our issues around reprioritization? We have many duplication, leakages, pilfer. So all this is, we may not need more resources, we just need to reorganize ourselves. Then of course, the other function being pooling. And of this, we take note, we have to pool in a prepaid mechanism, and also that we have to pool resources and also pool the risks. And therefore, the issue of the healthy and the sick, the rich and the poor. And therefore, this calls for the principle of solidarity. So you may feel you're contributing 10,000, another one is paying 10 shillings, but that is the principle of social health insurance, that you pay for that other person who really needs it the most. Then, of course, the key thing, which is what we are grappling with now, is the strategic purchasing. And maybe for us to note that in this space of strategic purchasing, there are many actors. You have the beneficiary who has a voice. You have the provider who has to give the service and also needs an incentive. You have the payer who has to pay for those services, purchase that benefit. You have the regulator who is now government. So at what point or how do they work in that space of strategic purchasing? So, and we also take note that there are various purchasers of health services. Key to that is the government. Government is the primary purchaser, and we know most of the services it has to purchase for its populace is community service, public health services, preventive, promotive. That is really the mandate of government. Of course, other supplement partners really support us in the vertical programming, where you have the strategic commodities or programs, including the HIV, TB, malaria, vaccination. So everyone has a role, but how do we work in that space? Of course, if you're to look at strategic purchasing, we know what we want to purchase. Of course, it's the benefits. And I believe part of the questions we received a lot on the benefits. And how do we want to purchase those benefits? Of course, the issue of, can we enter at a certain point, the PHC approach, or do we want to start at a higher level? Of course, how do we want to pay the providers? Which is the best method? How do we want to contract? And whom do we want to purchase from? Of course, the issue of the public-private FBOs. And when do we all need to start? Is it a time clock? Do we start all at one time? But of course, the call is for all of us to start at the same time. Also in matters strategic purchasing, then how do we want to manage the claims management process? So in terms of that, that was the overview of the UHC reform. That key to that is mandatory contribution. We need to move away from over donor reliance. And lastly, that we need to prepay for health, invest in health. So move out from paying directly to the provider. If the mechanism is insurance, then that is the method we may need to deploy. And of course, the Social Health Authority gave the status of implementation. The update was for matters enrollment, registration, we stand at 18 million. In terms of contributions, definitely the form of people in formal employment seem to be contributing more at this point. And remember, we're at 32%. So what does that speak to us in terms of entitlement to benefits? So we must link you're contributing to access. So I think at that point, we can talk of a fund that is not peaking, a fund that is not mature, and then also working towards how do we contribute more to it and how do we also net the more informal sector. And key to that is informal sector is not poor, it is not rich, it is just unpredictable. And in terms of benefits, I think we take note, it's a phased implementation, and this has been limited by the resource envelope. And of course, in terms of claims, my colleagues will talk on how does the transition look at, and also what has been paid out so far. And of course, the issue of empanelment, and e-contracting. I think that the providers have been keen to that, and that update was provided, and we shall have it in the presentation. So key to that is NHIF, SHA. The issue was really separating functions, and that is what is now playing out in that field of strategic purchasing. Thank you, and back to you, Amina.
Thank you. Thank you very much, Dr. Ari, for that summary. Thank you for explaining the differences between what we mean by strategic purchasing and what the government has in plan. I hope that's clear. If you have any question, please don't hesitate to put it in the Q&A. But perhaps we might be addressing them very soon. So that is the part on the summary. Let me move on to the questions and answers. And the first question, what we did was we took all the questions and blocked them into themes that people can be able to understand, so that they also understand what they need to understand where it is addressed. So for sure, the legal framework is the law that was published in October 2023. But as an overview, we're discussing health financing in all. So we had questions on health financing landscape in Kenya. There were general questions in terms of what is contribution of government, what is donors, what is out-of-pocket expenditure. So, Dr. Valeria, do you mind giving a rough, brief overview with this perspective in mind for the audience to understand better?
Thank you, Dr. Amina. As I alluded to, of course, the health financing space has several players. And as it is right now, we are at a total health expenditure of 550 billion, and that is as per the last report of the National Health Accounts. And in terms of how each player contributes, of course, we have the government contributing the most of it at around 52%. We have the donors roughly at around 17 to 19%. The one that concerns us mostly, of course, the households contributing about 24% to health. And then, of course, we have the corporations and the private sector at around 6%. And in terms of how the community health services are financed, this is actually the obligation of the government to ensure they do so. And this is provided through the exchequer bucket, the budget to each entity, the county governments and the national government. Each is supposed to prioritize and plan accordingly for these services. So in essence, we cannot say the bulk of this is not a SHA function. It may be a SHA function if we decide we need to purchase something or a service at that level. But in essence, the governments of the day need to prioritize the public and the community health services. And of course, on the issue of donors phasing out, this has been, it's a transition or a gradual process. And we are in the process of developing a framework on how exactly to transit. Are we transiting first the commodities, the human resource, the information systems? So all that we are planning, we're working on that as the ministry. Thank you.
Thank you. Georgina, might you have something to add on as an insight as we proceed to the next discussion? Georgina?
Yeah, I think it was well covered by Dr. Valeria.
Okay, thank you very much. So I hope that's clear in terms of what the healthcare financing landscape looks like in Kenya. Of course, we still have a budget, and the budget caters for the other parameters from human resource to public health in terms of community health promoters, for even capital investments. Those are still captured within the budget. and we have the donor aspect and the out-of-pocket expenditure. Okay. In terms of SHA progress, how is SHA sustainable? Kaboro, I think I want you to answer this question as our health economist. What is the role of the premiums and what is government allocation?
Thank you very much for that question, Amina. And in case I'm not audible, you can let me know. But
You're very audible.
so far, we have done our costing and modeling based on the estimations which we had done to make sure that the project is sustainable. If you remember, one of the major issues we had with NHIF was the sustainability aspect, where it was not able to meet its obligations and facility reimbursements were not happening as they should be. So for sure, we have ensured that the package that is being offered can be met, or the social authority can be able to meet. That has been done. Very comprehensive modeling on the amounts which we can receive, both from the formal sector and from the informal sector. And due to the unpredictability of the informal sector, especially at the beginning, we have done a second thing, which is the progressive rollout of the benefit package. You realize that some of the packages that we have rolled out currently are not as comprehensive as we would wish. So there are some packages which will come on board within the 6 months, depending on how we see the contributions rolling out. And so far, they have been coming out well. So we foresee that in the month 6, we will roll out more benefit packages, and some will come up, I think, within a year. So that was the one. We need to ensure that especially the social health insurance fund, the middle fund, is able to sustain itself. The second thing we are looking at is the government contributions, especially for the two funds. So we have contributions going to the primary healthcare fund, which government has been allocating so far, and we have been able to meet the obligations. For the emergency, chronic, and illness funds, we haven't got a sufficient funds as we wanted. So you realize that most of the packages in that fund have not been rolled out. And we can only roll out once we have government commitment to financing, which we have lobbied in the current supplementary budget. We are waiting confirmations before we roll out that package, but we cannot roll out until the funds are actually committed and are available for rollout. So far, we have been receiving sufficient funds for the social insurance fund and for the primary health fund, and something small for the ECCIF, or for which we are currently on rolling out the ambulance or ambulatory care. Ambulance care, sorry, not ambulatory, ambulance care. I hope that is quite comprehensive, Amina. Now, on the issue of disbursement to providers, that one I will leave to Dr. Hauser or Dr. Tracy. I think they would have the most updated figures, but I'm sure by the moment the facilities have been receiving their reimbursement quite well so far as the funds have been utilized. So, Amina, back to you.
Thank you, Kaboro, for that. I forgot I was on mute. Yes, Dr. Tracy is here with us from SHA. She's the Director for Benefits and Claims. And we also have Osoro, who has joined in. Osoro is representing Hazel from the other discussion. So the question on how much has been allocated into the three funds, perhaps, and how much has been dispersed as provider reimbursements, I think is better placed with the two. So Dr. Tracy, karibu. join in as we also give time to Osoro to address some of the questions. Osoro, if you're able to speak kindly. Yeah.
Thank you. Kindly confirm whether you get me loud and clear.
Loud and clear.
All right, let me start with the questions that have been raised that were in the last meeting. And I'll start with the issue of SHA advocacy and the communication plan and the strategies for SHA sensitization. We are doing public education campaigns, disseminating information on SHA through social media, and community outreach programs. We are explaining the benefit package available and at what level, what we call the Kenya Essential Package of Health, the KEF level, and of course, appealing to members of the public to register. We are actively engaged in stakeholder engagement, and we are collaborating with government agencies, NGO, private sector partners, and of course, community organization to expand reach. On the issue of advocacy through policy and leadership, we are engaging policymakers at high level, including parliament, and we are also training SHA champions who do advocacy on behalf of SHA. We are also conducting targeted community sensitization, of course, based on data. We are conducting county-level outreach programs, roadshows. We are also holding town hall meetings for grassroots mobilization. We are also available on the digital and print media, whereby we are utilizing the radio, TV, print and social media campaigns to reach a diverse audience. We are also producing educational content, testimonials, and explainer videos. We realize the importance of capacity building, especially for healthcare workers and community champions. And currently, we are training public educators, healthcare workers, and local leaders to advocate for SHA and educate community. The other thing we are doing is how can other institutions and organizations contribute to SHA advocacy? We are looking at corporate sponsorship and corporate partnership rather. We are saying that employers and professional bodies can integrate SHA awareness into their workplace policies so that their members are empowered. We're also looking at NGOs and community-based organizations which can assist in grassroots mobilization and capacity building. We are using media houses and influencers, whereby we are promoting SHA through sponsored articles, talk shows, and panel discussion. Lastly, we realize the importance of diaspora engagement, and we are mobilizing Kenyans in diaspora to contribute to SHA programs and engaging them through a program that we are rolling out called Ask SHA, whereby we sensitize them on the scope of coverage and SHA regulations. There was a question that was raised in the last presentation, whereby some members did indicate that they were unable to access services. What we have noted in the recent past is that employees have experienced denial of healthcare services during specific periods because of non-remittances. Remember, the individual accounts are linked to payments, and failure to pay automatically disqualifies one from accessing services since SHIP is a contributory scheme. We have also challenges in payment processing due to incorrect remittance format. This is a scenario whereby employers have remitted in the time and manner prescribed, but some information is missing. Specifically, this is more pronounced for people who use real-time gross settlement, RTGS, or electronic gross settlement, ETGS, who in their narrative, they don't indicate the unique identifier what is known as the payroll registration number, which is acronymed PRN. There's a question on exhaustion of benefits before the year ends. That is the limits of liability. And when a member exhausts their benefit limits before completing a full year of coverage, they are not left alone. SHA provides a fallback mechanism through the Emergency Chronic Critical Illness Fund, ECCIF, which ensures continuity of care for members in need. This fund serves as a safety net, which allows beneficiaries to continue accessing medical services despite their limits of liabilities being exhausted. I will pause there and perhaps invite Dr. Tracy to respond to the other questions raised. Thank you, Chair.
Thank you. Thank you, Soro. Thank you for going straight to advocacy and communication. It's truly an important pillar in healthcare. We need to not wink in the dark and be able to address. As usual, if you have any questions on that, you can post it in the Q&A, and I hope that section of the questions that were asked last week has been fully addressed. So just back to where we were still on questions regarding the SHA process. Dr. Tracy, I hope you're audible, and I hope you could address these specific questions that were asked. So it looks like Dr. Tracy John is not with us. We have with us also Dr. Elizabeth Wangia. Atari, would you want to? Although these questions are specifically to SHA people, so, but Dr. Wangia, maybe you can jump in and say hello and give a brief overview on the discussions.
Yes, good afternoon to you all. I think I missed out on the specific question being discussed. Maybe you can just quickly let me know, then I can respond.
Yeah, so it just generally on the health financing landscape, maybe we can go back until we have Dr. Tracy with us. We did a summary on the health financing landscape in Kenya, section on how the donor transition is, what are the vertical programs. I remember there were a lot of questions heavily on understanding what is vertical programs when you had discussed it. So perhaps you could shed light, because they were actually addressed to you, in terms of what are vertical programs and what are the plans. Are we planning to still remain? What are the advantages of having them as vertical, and when can we be able to integrate them? Over to you.
Yes, so thank you so much, Dr. Amina. I think the summary presented is quite good. I think what is of interest right now is especially what's been happening, globally. You can see Trump, the effect of the US support freeze to Kenya, having a direct impact on the health financing landscape in Kenya. Given that I saw there was a question last time on what are vertical programs. And basically, when you talk of vertical programs, we are talking of the standalone programs like the HIV program, TB program, malaria program. All of these things are standalone services, which, yes, they are good. It was good, especially when we had when HIV had been considered an epidemic. But now, as the situation stabilizes, we want to think of then how do we integrate for more efficiency, because there's no point of probably having community people to handle, say, HIV patients or TB malaria patients, when you can have this one community health promoter who can handle each and everything. So you see, that aspect of integration then helps in saving resources. There was also the looking at just the landscape within Kenya. We know that the different sources of health financing, either you have the government budget, and this is both at national and county level. Then we have from the private sector, and private, actually, the out of pocket is considered private because you are privately contributing. We have insurance, and we have the donor financing. So basically, when I think there was that misunderstanding that can we account for the entire total health expenditure? Because I'd said our last total health expenditure was around 550 billion. So there was a question on then how do we account for each and every point? But then the thing about total health expenditure is the total of from all the sources. So the government contributes around 51%, around 49%, with the donors coming very closely, then the rest follow. So what we can do maybe to enhance the financing landscape is to see then how do we bring all our resources together in one plan. And within this one plan, we say these are our priorities, and this priority will be taken up by this donor, this priority will be taken up by exchequer, this priority can be taken up by insurance, so that at the end of the day, we don't have double financing. And therefore, once this is all aligned, then it becomes easy to take note of the, to even measure outcomes based on the inputs provided. So back to you, Dr. Amina.
Sorry. Thank you very much, Dr. Wangia. I'm sorry, I didn't realize I was on mute again. I'll now go to financing and sustainability thematic area, where we had some questions on contributions, how we came to calculating it. And I'll address these questions to Stephen Kaboro. How are the contribution rates estimated? How did we do? What is proxy means testing? Break it down to us in simple English. Thank you.
Yes, so I'll give a very brief overview. Members, as you are aware, we have a session on proximity testing, which we will dive deep into it and how it's calculated. That session will be on the 6th of February. So we hope members will join us as we discuss in depth into proximity testing. But just to give a very, very fair overview, proximity testing, we used data which we have, government data, which we could see okay, giving a small background, do you know the estimating how much the informal sector should pay is actually not very straightforward. One way we can do it is to ask individuals how much they earn. Now, the problem with that is that, most Kenyans will tend, of course, to give the lowest amount of how much they actually earn, so that they get the lowest premium. So we noted that there was a need to have a more mathematical way of estimating income. And in this way, we were looking at three key indicators: an individual characteristics of the individual, characteristics of the household, and the environment where they live. So those three indicators are correlated to wealth, and we were able to look at that correlation through regression modeling. So for individual, we will look at, for example, the age of the individual, individual specific characteristics like education level, issues like how the household is composed, like how many members are there in the household, And then for the household characteristics, we will look at the individual where they live, the kind of house they have, the kind of things they use in the house, etc. And the community level, we will look at the specific geolocation of that household. You know, that also determines a lot in terms of the income. And for that, we had data which we used to correlate to the income level and estimate how much this individual will most likely be earning. We will realize that, for example, if you look at people who live in Kerereshwa in Nairobi, most of them will have more or less almost the same income. If you go to Korogosho, more or less they'll have, the disparities will be quite few. And with that, we modeled a means testing instrument, which now estimates the income levels of the household. So it has been working so far. We have around 3 million households which have undertaken PMT and they have been given the rate. In case an individual feels that the rate given is not commensurate to the income, we have two levels of contesting that PMT. So the first one is an automatic appeal, which is embedded in the tool. So you'll be asked a few more questions. And once you respond, the model automatically reclassifies you if it feels that what was given was wrong based on the new information given. The second model is whereby you could, in case it still doesn't, you don't agree with the model, you could contest it as the SHA office, and the SHA office will guide further. Now, most of the questions that are asked are not actually asked to the individual. So we use a total of 98 variables, coming from around 58 questions. And these 58 questions, out of the 58 questions, the ones that are asked to the individual are, I think, around 18 questions that the individual will be asked. The rest of the questions, around 20 something questions, are accessed by the model directly from government databases. So the model will be able to get most of the indicators from what is already inputted into all the government systems. Now, the system, I think this is the first interaction we're doing with the system. It has been working well so far, but we have a target of refining the system by the end of this year, once we have more access to more government databases. In the end, we foresee a situation where we don't have actually to ask questions. We should be able to get almost everything from government databases for that individual households. And these are questions or variables which have been filled by the individual over time for many government projects, for example, land use. We have a comprehensive database on land use. We have comprehensive databases on education levels, on the individual approvals for sale, buy, purchase, sale of motor vehicles, of land, of buildings, ownership of buildings, etc. So in the future, we want to move away from asking individuals and being able to extract all this information from government databases. But that is going to come by the end of the year. So far, we have registered 3 million households, as I have indicated, and I do know that most usually ask how we identify the vulnerable populations. So the model actually does not do vulnerability analysis, but we do have, as per the law, and as guided by the legal instruments that we are using, the Ministry of Social Protection does carry out vulnerability analysis for populations with assistance from counties. So that's what we are relying on to identify the vulnerability. Now, so far, we have been able to get an average premium of around 600 shillings, which is still quite low. The target we have is about 1,100 shillings as the average premium for all households, from those contributing 300 shillings to those who will be asked to contribute 5,000 and above. And for this, currently individuals are required to contribute monthly, but this is just a stopgap measure. You see, as per the law, individuals are supposed to contribute yearly to the fund to ensure that it is more sustainable and there is no adverse selection whereby individuals only pay when they visit health facilities or when they need care. So in the future, individuals or households will be required to pay yearly, but the government is working out on modalities on how the government can provide advance. So the government pays to share for your yearly contribution, and then from whichever department that gives you that access, if it's Hustler Fund, if it is Fuliza, etc., you can have an arrangement where the individual now will be paid to that financier monthly at zero or very minimum interest. So I hope that was a small overview. As I have said, we will have a comprehensive presentation on the 6th of February. So that will be more comprehensive and we can be able to answer most of your questions there. So this is just a teaser, and back to you, Hamida.
Yeah, thank you, Kabor. That's a very good comprehensive overview, and it's good for the listeners to know that 6th February it's going to be expounded further. And maybe a word from Osoro. Osoro, you've been there as NHIF and now SHA. So what inputs do you have to add, especially when it comes to this contribution? What are the trends are you seeing at the moment, this 600, in terms of sustainability, in terms of adverse selection, from your perspective, because it's rather unique in terms of where we were and where we're heading to.
Thank you. As indicated, the rollout of SHA commenced on 1st October 2024, whereby we did implement the new contribution structure that is pegged at 2.75% of the gross salary for those people in salaried employment. And for those who are non-salaried, it is 2.75% of assessed income through proxy means testing. And for those who are in need of financial assistance, of course, they have to subject themselves through proxy means testing. And the functionality of proxy means testing is twofold: to determine the premiums that are payable by the non-salaried households. Secondly, to determine the persons who are poor and vulnerable, who are referred to as indigents, who are paid for by the national government. Having said that, we want to thank Kenyans because they came out in large numbers. They've been able to enroll SHA, which is a shot in the arm, and the confidence that they've demonstrated towards SHA. In the latest summary statistics that we have, as of yesterday, we had in excess of a total of 18.5 million Kenyans who have registered to SHA. Of particular note, when you look at the gender parity, you realize that when you look at males, 48.7% have enrolled to SHA. When you look at females, it's 48.77, which indicates that equally both genders have enrolled. But when you look at the paid up members, who total up to 4 million, for the formal sector, total members at 3.2, and the reason being because it is mandatory by law. When you look at the informal sector, we are talking of members who are fully paid up to be in excess of 876,000. And of course, when you look at the declared dependents, it stands at 3.9 million. And the average registration age is 36. This data is telling a story that we have a gap when it comes to the informal sector, and we need to redouble our effort so that the informal sector, who constitute about 83% of the people, should be able to be onboarded. When you look at registration by age group, you realize that the ages between 18 up to 35 years of age constitute 35% or 4.8 million. They are closely followed by the age group between 36 to 55, who constitute 32%, and above 55, we are talking of 14.7%. This tells us that more emphasis needs to be put towards or targeted messages towards these elderly persons so that they can enroll. And what is coming out is that the people who are tech savvy below 55 years of age are the ones who've been able to on board. Of particular good note is that the population that is enrolling has been increasing gradually since the rollout in October, and the numbers are going up as we continue undertaking public education and sensitization. We'll be preparing a detailed report in the coming week of the informal sector, whereby we will look at the challenges, the key highlights, the challenges and recommendation, including sustainability. How do we ensure that in the spirit of universal health coverage, no one is left behind? The other thing perhaps I would like to say is that we note that dependent declaration is very low. We are talking of 3.9. And from the Kenya National Bureau of Statistics report, the average size of a Kenyan family is about 3.8, rounded up to 4. So we anticipate from the 18.5 million members is that we should have registered triple the number that we've been able to achieve. So going ahead, we have set into place mechanism to target declaration of dependence. And when I talk of declaration of dependence, we are looking at the spouse and children arising out of that particular marriage. When you do a quick baseline survey for the non-salaried, who are also the informal sector, one of the things that pains them is low awareness and sensitization. Many of them are unaware of the extended scope of cover, the 18 benefit packages that are administered under SHA. And it's incumbent upon now as SHA to reach out and communicate to them the benefits that accrue from being a member. Is the issue irregular and unstable income, inconsistent earnings that affect affordability? Many of them do not have a stable source of income. There is the issue of a lack of formal identification. Some of them do not have national IDs, and as such, they are unable to enroll. When I shared the data on the enrollment based on age, you noted one thing, that the higher the age, the fewer the limitations. And our baseline survey reveals that there is limited digital literacy. People beyond 55 and above struggle with online registration and proxy means testing that Kafora told us about. There is no efficient enforcement mechanism. Remember, these people are not employed. They are not in a payroll where you can be able to follow them with that. So we are looking at ways to incentivize compliance so that they can be able to join. There are competing financial priorities whereby health insurance is deprioritized over daily needs. People looking to pay rent, school fees, food, instead of paying for health insurance coverage. I want to end it there and hand over to the chair. We will be making a detailed presentation, I think on 6th with Kaboro, when we will share a detailed report on informal sector registration since the rollout of SHA. Thank you.
Thank you. Thank you very much. Thank you for that elaborate discussion. It's quite insightful to actually see the number, and interesting how we have good representation from both male and female within it. And to actually put a number on how many people are paying in the informal sector, 876,000. compared to 3.2 million in the formal sector, which is a very small percentage in terms of our population, and I hope we'll be able to reach optimum so that we can be able to sustain the benefit package. In terms of the donor transition, Dr. Valeria, we are classified as the low middle income country. That means we're phasing out in terms of donations and support from other countries, and I think it has come sooner than we had anticipated. So what are we doing? What are the commitments and what are the strategies for increasing our domestic resources? And why is this topic really, really fundamental for us as healthcare workers and also the other listeners within the health sector? Why is it important for us to have a common message in terms of the importance of us to have domestic resources? Dr. Valeria.
Thank you, Dr. Amina, for that question. I think that is one aspect that is quite complex, but really it's the rebasing means we should be raising more revenue as a country, and the sustainability aspect of it. How do we make sure what we have, we are using it efficiently? And therefore the issue of the exiting or the transitioning becomes important. I think the challenge has been, we keep saying, or let me say the donors say they're leaving, but really no one is leaving, and everyone is left to ponder the next step. But indeed, we are in the process of working on a framework that will help programs that are highly donor supported on how to transition. And I think I had alluded to the fact that we have various aspects. We need to decide what we want to transition first. Is it the human resource? Is it the commodities? Is it the health information system? And of course, now the finances also have to follow that. So that has been the plans we have to make, and it looks like it is coming sooner than later. And on top of that, also as government, or do I say treasury, that we need to see how we look for resources within and how to generate more. Is it, I'm not sure whether we have enough fiscal space, but really that discussion has to take place. And also, at least for health, how do we prioritize what is allocated to health? And then we work on our PFM issues at that. So the issues of stockouts, I think that we have to work at it at the programming level. And really we see how the national government, county government work on these strategic programs. Thank you.
Thank you very much. Dr. Wangia, do you have anything to add?
Well, not really. Maybe just to mention that most of the donors, as we talk of donor transition, we actually need the exit plans from the donors themselves. I know as it is right now, we have the exit plan for Gavi and PEPFAR, I think. So as we talk of donor transition, it's important for them to tell us how are they transitioning? How do they foresee themselves transitioning? In what proportion do they transition? Because we don't expect the transition to happen overnight. Yeah, so as we think of that, and as Valeria correctly said, that you may want to ask, what are we transitioning? Are we starting by transitioning commodities and saying, maybe like for HIV, we do the first line, or for TB first line, then as the donors continue doing second line, same for vaccines. So it's just a matter of having a discussion and knowing what is the impact of the transition, and also advocating for additional resources from our end. Thank you.
Thank you. Thank you, Dr. Ari. And thank you for your wonderful work. Dr. Tracy has joined us. and I would love to hear your input. There were many questions regarding the transition done. A lot of people feel like I contributed to NHIF. What happened to my money? Has it moved to SHA, especially in the vulnerable population? And if we can shed in more in terms of the numbers, how many people had contributed, and there was the rollout, it will give more light. Dr. Tracy, karibu. I know you had some technical challenges, and we're happy to have you here. While we're waiting for Dr. Tracy. Oh, thank you.
Thank you, Dr. Amina, and apologies for not having been able to join earlier. In terms of the question you've asked, I believe in terms of the data that could be can be supplied by a different from a different part of SHA. I don't know how far you had gone in whether you had already addressed the issues of registrations and contributions. Because
not yet.
Okay, because that team will be able to address on that one.
Okay.
Thank you.
Thank you. Osoro?
Yeah, thank you, Chair. I can be able to address the issue of membership as of 30th September 2024, when NHIF became defund. Now, I'll be able to address it by giving a breakdown of membership. Under the former NHIF, we had members classified into 3 categories. We had the formal sector, people in employment, informal sector, and finally, sponsored program. Now, as of 30th September 2024, under the formal sector, we had a total of 5 million members, of which 4.3 million or 85% were active. And when I say active, they are members of regular and good standing who had remitted premiums to date. When you look at the informal sector, the total membership stood at 9.2, of which it's only 1.7 million members who are members of regular and good standing, translating to 19%. Finally, when you look at the sponsored program, whereby we had a total membership of 2.6 million, of which 1.3 were active, translating to 53%. Now, when you look at the cumulative total membership under NHIF stood at 17 million, active membership stood at 7.4 million, translating to a retention rate of 44%. Thank you.
Thank you. So how many of that 7.4 million who had made contribution? Of course, when it comes to formal sector, the rollout was automatic. They were just paying monthly, but some of the informal people were paying like 1 year in advance, or even in the sponsored programs. I think the audience wanted to understand better, because a lot of people have been complaining, but when you see the number, you actually get to understand how the rollover took place.
Thank you, Chair. Indeed, and to confirm that for the non-formal, the non-salaried households, the self-employed, we had a huge number of them making upfront payment. We've come from a dispensation whereby for those members who are accessing specialized services, and when I talk of specialized services, we are talking of major surgeries, organ transplants, total hip, total knee, open heart surgeries. They were being told to remit upfront for either 24 months or 2 years, 1 year, and the rest. And we had quite a huge number that paid. But I want to add this, that under SHA, we made arrangements for those prepayments to be transitioned. Remember, the Act, the regulations, and the transitional committee report indicated very clearly that the former assets and liabilities of the defunct NHIF were to be transitioned to SHA. I want to use this platform to confirm that indeed we transitioned the prepayments. But I want also to issue a rider after we transitioned the prepayments. For the non-salaried households, they were supposed to submit themselves to proxy means testing, after which the results were to guide on how to spread the amount in the SHA database. We did write messages requesting members to undertake proxy means testing, and I'm glad that quite a number have responded. They've done proxy means testing, and based on the amount that they had paid, it's been spread in the SHA database and they can access services. Same case to the employers, but I also want to indicate that we have also a small proportion of the non-salaried households who've not been able to undertake means testing. And as such, it's a challenge for them to access healthcare because the amount can be seen in the system, but it has not been prorated. So we are still reaching out. We've embarked on a robust sensitization campaign to undertake proxy means testing so that they can be able to access services. Thank you, Chair.
Thank you. Thank you very much. Now I'll just quickly go to registration. Osoro, you will allow me to continue to indulge you. Registration, we had so many questions on registration from the people who don't have ID. What happens? What do you require other than your ID? How do we deal with such scenarios? And out of the 18 million people who have registered, if you can break down, I know you've done for gender, but if you can break down how many are not, I want to run away from the word principal, but how many are the contributors and how many are dependents within that? Karibu.
Thank you, Chair. Now, if I got you correctly, the question that you've asked is the number of households that has been onboarded to SHA.
Yes.
Now, thank you. I get your question very clearly. Now, when it comes to number of households that has been onboarded, what we currently have is the number of members that have registered to the SHA portal. And I did indicate it's 18.5. Currently, we are working on a report which will be able to share in the coming week on the number of households that have been onboarded. Of particular note, I note that some of the principal members have not registered their spouses, and as such, the data may not be reflective of the actual households. Because under SHA, it is a requirement before you enroll your spouse, he must be registered to SHA. So it is works in progress. We'll be able to share a detailed report segregated into households. Thank you.
Thank you. And on the issue of ID, if somebody does not have an ID, and not in terms of abstract or what have you, but if they do not have a passport, an ID, an alien card, what happens?
Thank you, Chair, once again. We appreciate that there are scenarios whereby people may not have the necessary registration documents. And when we look at it, we are talking of aliens, refugees, expatriates that are working in this country. And the Act and regulation provides that we register asylum seekers, and the document that is recognized by law is called an asylum seeker's pass. We also have a movement pass. We also have a letter of recognition issued by a competent government institution. We have a refugee identification card or a conventional travel document. That is for foreigners. We also have scenarios whereby we have underage mothers giving birth and they are not of the age to get national IDs. What SHA has done and what is currently under piloting is we've set aside a provision for a temporary ID, which is a unique identifier that is validated before you are onboard to access services under SHA. So the spirit behind it is to ensure that no Kenyan is left behind when it comes to access of healthcare services. Thank you.
Thank you very much. Dr. Tracy, in terms of registration, there were many questions in regards to how do you benefit from registering? Does it mean that if I don't contribute, there's nothing that the government of Kenya would do? So what does it mean in terms of if I register, what can I get? And if I contribute, what can I get even further? And also in terms of level 4 facilities, so that you can address all the questions at a go. If people are living around level 4 facility, why are they not allowed to get perhaps not, instead of outpatient, I'd rather say the primary healthcare fund, if they can derive benefit from that. Thank you.
Thank you very much. First, on the question on registration and the benefits that are accessible, when we look at how the benefits are structured, we do have the 3 funds providing different types of benefits. And the primary healthcare, under the primary healthcare fund, which covers the lower level facilities, that is services, primary healthcare services, sought from level 2, 3, and a good number of level 4 facilities which have been onboarded. These benefits are accessible to those persons who are registered to SHA. What that means that since the fund is financed by the government through the exchequer, then a person doesn't need to have paid premiums to be able to access these benefits. They just need to be registered members of SHA. The other fund, which is the Social Health Insurance Fund, that is a middle fund. This one covers benefits that are provided in the higher levels of services, of facilities, and that is starting from level 4 and level 5 and level 6 services. And where a level 4 is contracted to provide primary healthcare services, then SHIF covers the other services like the inpatient. This fund, the SHIF, is a contributory fund, and that means that then a person needs to have registered into SHA, and in addition to registration, they ought to have done their means testing and paid their premiums, if that is a informal sector. And for the formal sector, they need to be registered and to have paid up their premiums to be able to access benefits under this fund. The third fund, the Emergency, Chronic and Critical Illness Fund, just like the Primary Healthcare Fund, this one is also financed by the government through the exchequer. And as such, for benefits like emergency services, which have already been rolled out, these services, the person doesn't need to pay. That means that they can access the benefits, those benefits of emergency services, even if they are not paid up members into SHIF. In terms of proximity to the primary healthcare facilities, that concern was raised a while back, and it was actually deliberated and considered to have been a valid issue. And that did inform the decision to bring on board more level 4 facilities to be empaneled and contracted to provide primary healthcare services. And as such, even as it is now, we do have a significant number of facilities which are level 4, which are providing primary healthcare services. That is the outpatient component of the primary healthcare services. And that means that access has become better, because it would be very rare to find a person who lives somewhere where we don't have proximity to either level 2, 3, 4. And especially considering we are looking at across the divide in terms of ownership of a facility, whether public, private, or a faith-based facility. And that has really gone a long way into improving access as far as proximity to the health facility is concerned. And I believe that answers the 2 questions, I hope. Thank you. Back to you, Dr. Amina.
Thank you very much, Daktari. I hope I'm audible as well. As I'm sharing my screen, I'd just like to put to the attention of the audience. On the webinar chat, you'll be able to see a link of all the presentations that were done. Kindly just download them, because we will be unable to share in any other format. This is the easiest way for you to access these documents. So on there, KNH Research has shared. Please just press the download button, and I hope we have above 55 who are not technically challenged, and even the one who are 55%, I'm sure they're well, they don't have technological challenges if they're here. So in the interest of time, I'll quickly skim through some questions, and hopefully I'll be able to get some answers in under 1 minute from the audience, from the speakers. So I'll jump straight to the access and benefit package. This is the place that had a lot of questions, and unfortunately, because of time, it's running off, but it informs us as the organizers to perhaps have one dedicated session on just the benefit package, which will be done with time. But for now, Dr. Tracy, if you don't mind to indulge us, how are we planning to disseminate I think we've done the part of advocacy. So how do we guarantee we have the same package for all Kenyans? And if you can give us the science behind it in under a minute. There's so many questions there. I think you can see them, but how can you shed light for the audience so that you can answer what they were trying to ask?
Thank you very much. In terms of the benefits, I'll try to keep it brief in the interest of time. In terms of the benefits that are accessible to Kenyans, indeed, one of the reasons why there was a need for some change was to make sure that we have benefits that are harmonized and accessible to everyone in a manner that brings equity, whether it's the intervention itself, the service itself, or it is a tariff, how much the service is reimbursed or charged at, to make sure that we also have a unified benefits without having fragmentations, where we may have had several schemes and various benefits packages. And so far that is an objective that we would say has significantly been met, because irrespective of where the person is or how much they have contributed, where they work, irrespective of somebody's background, the benefits are the same. Once we say this is a benefit for primary healthcare fund, it cuts across board. The benefits for social health insurance fund, again, it is unified. And the same goes for the benefits on the emergency critical and critical illness fund. And when you look at the tariffs again have been harmonized. So if we are reimbursing outpatient in a government dispensary for a certain amount of money, or a government sub-county hospital, the same amount of money is reimbursed for the same service delivered in a faith-based facility or in a private facility. And that means that those tariffs are harmonized so that patients have that equity. In terms of the mechanism, the provider payment mechanism that we are using, we've also seen the harmonization of that, where if we decide we're paying this facility using capitation for a certain service or a fee for service, whichever provider payment mechanism we choose for or has been worked out, it cuts across board. And therefore, we can say that we have significantly achieved that harmonization of the benefits, the services, as well as the tariffs and the provider payment mechanisms. And Kenyans are able to enjoy the same benefits. Over to you. Thank you.
Thank you. So, Daktari, you'll allow me to continue indulging you because this section is heavy on your side. Maternity. Maternity is one of the most heavily asked questions from Linda Mama to now Sha. How are we continuing it? And how do we ensure that we have 100% coverage so that we don't lose track of what had begun? On the gains we had had. Over to you.
All right, thank you. That intervention, that is the maternity package. This service, as we all do acknowledge, is a very critical service that we try to make sure that we continue improving it so that we don't lose the gains that have been made as far as the mother and child health is concerned. So when it comes to financing of the maternity services of the package, several things have been done under SHA from where we are coming from. And one of the things is that there is improvement in terms of the reimbursement amounts that are given to the provider who provides the maternity package for most of the providers from where we were before. And that means that the provider then is able to offer quality service because then the inputs that are required to provide that service are well taken care of by that reimbursement amount. Other than that, in terms of the patient, under something like Linda Mama, before the Linda Mama project as it was before, we have improved it now because you can see before a mother would only be covered for maternity service itself, the delivery of the baby and the immediate post-delivery, as well as the child for the immediate after birth. But in this new system, when a mother is registered and they have undertaken means testing and they've been considered to need support for maternity, then the mother is registered and paid for a premium. Instead of just paying for the maternity service, then they get payment for premium. And that is, they become now a registered and a paid up member of SHIF. And what that does is that it means now the mother can access not only maternity services, any complications that may arise, the child care, but also now enjoys the full benefits that are defined under Primary Healthcare Fund, under SHIF, under ECCIF. They are able now to access all those benefits, not just for the mother and the child, but also for any dependents that this mother may be having, whether they are other children or it is a spouse. So then it protects now the mother much more than before. Again, in terms of access, we see there is improvement in access because the mother will be covered, and there is that leeway to be able to deliver or seek the services that they require from facilities that are allowed to offer those services without limiting them to one level or two levels. So I would say that in terms of the reforms, the maternity package has really been improved, and we hope to see better outcomes and see more mothers protected for the betterment of maternal and child health moving forward. Back to you, Dr. Amina.
Yeah. Thank you very much, Dr. Ari. And in the interest of time, I would not like to ask more questions. We have scheduled in another session in terms of access, the benefits and the tariffs. There are many questions pertaining to that, and we'll be able to address that in another forum and in another session. But in the interest of time, just to summarize the discussions, yes, we've started a webinar series through the guidance of our cabinet secretary. She gave a directive for us to be able to come in together as Ministry of Health, as SHA, and also as WHO to bring in other countries and their experiences to be able for us to fully understand what we keep on repeating. What is UHC? What is SHA? And there's the UHC reforms, but this particular series is going to focus on health financing. UHC reforms is a bigger scope. It has the 6 pillars, and health financing is only but one pillar. And if you even look further, health SHA is one section of health financing. Health financing is bigger than that. And here we're going to specifically focus on social health insurances. This is what this series is about. This is the scope of the series so that people can have a better understanding. And I love how Dr. Tracy and Osoro has bring out what has been happening with SHA, and how Dr. Valeria and Dr. Wangia they have actually spoke on the general scope of what health financing is about. So I would love to have like a quick summary from the speakers in under a minute. Kaburo, what would you like to say? What's your parting shot? Osoro, while we're waiting for Kaburo to speak.
Thank you, Doc. My parting shot is to quote the words of Dr. Margaret Chan, the former Director General of World Health Organization, who once said that universal health coverage is one of the most powerful social equalizers among all policy options. I submit.
Thank you very much. Dr. Wangia?
So thank you so much. Mine now is more or less on the benefits, and just a comment that it's good to know that it's not possible for a government, to offer everything. The important thing is that over time, the benefits keep improving, over time. So basically, it's more or less a progressive. The benefit package is meant to be progressive with time. Therefore, I know there have been all these complaints. Why isn't this covered? Why isn't that covered? But just to reassure Kenyans and every other person that the process of the benefit package development and implementation is meant to be progressive. So long as we have a method of, reviewing, then we are on the right track.
Thank you very much, Dr. Dr. Valeria?
Thank you. I think my parting shot is information is power. And I think most of what is on the ground is we have not been sharing information and even how to get feedback from Kenyans. So we would like to put that as like we're willing to put in mechanisms to
Yeah, Dr. Valeria, we've lost you.
Same here.
Thank you. Georgina, would you like to have a word?
Thank you very much. From my side and from WHO side, we are happy to helping Kenya in going through this journey and encouraging much more discussions among all of us and the different stakeholders so we can actually make it happen. Over.
I'm sorry for that. Dr. Tracy?
No further comment. Thank you.
Thank you for that. So just as a parting shot, I guess it's always good to crunch the numbers. Out of the 54 plus Kenyans, only 18 million have registered. And registration actually means they have access to primary healthcare fund without making any contributions. And the only people who can actually access contributions right now as we stand are about 4 million people. The biggest difference is, unlike NHIF, SHA, once you pay, you can access service. And that's the pillar of social health insurance. Next week, we'll have Ghana. Ghana has very rich experience in what they're doing in terms of achieving social health insurance. And we're looking forward to the insights and the inputs they have so that we can all see the government's vision and adapt and reflect on how we can be able to gain insights from other countries and improve. I hope we will become advocates in this domestic resource section because we are all we have. Let's work for Kenya. Let's work for ourselves. So thank you very much. See you on Thursday.